And so without further ado, I'd like to warmly welcome our guest speaker for this evening, Dr. John Hwang. Thank you so much for being here. We are so excited to have you and to learn from you. I believe you're here with your colleague, Corrine, and we're welcoming to her as well. So I have handed you guys over presenter rights. So you should be able to access everything you need, but I'll be here in the background monitoring the chat. And again, if anybody has questions, please just feel free to raise your hand or put something in the chat, and we can certainly get to it as well. So welcome, John, and welcome, Corrine.
Awesome. Thanks so much, April, for the invitation. As you said, Corrine Out is the wound care clinician at the Complex Wound Center. We are a regional service. We've been around for about 10 years. In their wisdom, Fraser Health has decided to put us in the far northwest corner of the region in Port Moody, but we're working on that. Our referral forms are accessible on FormFast and on Pathways. So at the end of this presentation, we have my contact information. Feel free to reach out to myself or to Corrine any time. We've mapped out a pretty ambitious agenda for this talk, and understanding it's only about 30 minutes, and also understanding the severe limitations that all of you face providing wound care in a family practice setting in Fraser Health. We'll do the best that we can. We're basically going to go through a few basics of care. We'll touch on an approach to chronic or difficult to heal wounds. And then maybe we'll chat a little bit about when you might want to seek some help or a higher level of wound care.
Dr. Hwang, just if it helps, we actually have until 7:30. We don't end at 7. We go till 7:30.
Okay, perfect. Yeah. Thank you. This is sort of an intimidating slide. I'm not really going to talk about the anatomy of the skin, other than to say there are several layers. Each of which you can have problems with, depending on your underlying pathology. In terms of the pathology and in histology, we know that there are several layers. We're not really going to talk about skin erosions, which would be a separation of the epidermis from the dermis. All of you know things from medical school, like as you age, these ridges between skin layers tend to become shallower. You got fewer desmosomes, making older skin more susceptible to things like skin tears and skin erosions. But we're not really going to go through any of that. Similarly, it's important to know something about the different layers when you're getting biopsy reports, where lymphocytic infiltrates are. I'm certainly not an expert in any of that. We have dermatopathologists for that. But biopsies are a service that we do offer through the Complex Wound Clinic. But really, I don't actually do all that many biopsies, because, as I'll explain a little bit later, most of what we do can be is through pattern recognition. So there tends to be signs and symptoms that cluster together that inform us as to what's going on with a wound, what needs to be done, or what's been missed in the past. Now, all of you know that in terms of wound healing, there are 4 overlapping phases, starting with hemostasis, and then inflammation, proliferation or granulation, and then remodeling or maturation. And generally speaking, when you're talking about an acute versus a chronic wound is where there has been a stalling in one of these phases, and it's important to know these phases so that you know what the underlying treatment or how to theoretically get past these phases. For example, in entities like venous stasis, the wounds tend to be stuck in this second inflammation phase. If you're dealing with hypertrophic scars or with keloids, that's a problem with remodeling and maturation. And then the majority of chronic wounds or ulcers tend to be stuck in this proliferation or granulation. And that has implications in terms of how we treat. For example, if you're stuck in the inflammation phase, paradoxically, something like a steroid, which is an immunomodulator and actually reduces your healing capacity, might actually stimulate the process beyond which you need to get to wound healing. Didn't really know where to put this, so I put this right here at the front to talk about platelet-derived growth factor. Some of you may have been exposed to products like Regranix, which is synthetic PDGF. I really haven't seen it used a lot here. It's not readily available. You can prescribe it. Something I saw way more in the States that was commercially available. It's not that accessible in Fraser Health. For the record, if you have access to it, if you've written prescriptions, I think it works really, really well. What works even better is something like platelet-rich plasma, PRP. Really helps to get through chronic wounds in terms of that granulation and proliferation phase where things are stalled there. So just a pitch for PDGF or platelet-rich plasma if you have access to that product in a chronic wound. I think it works pretty well. Again, in dealing with either acute or chronic wounds, an acute wound is one that is going through those 4 phases of wound healing in the normal fashion. And a chronic wound is where there is a failure to proceed. And generally speaking, there is a reason that wounds fail to heal, either repeated traumas, as in the case of diabetic foot ulcers, poor perfusion with vascular ulcers, excessive inflammation, such as is the case in venous stasis ulcers or in inflammatory conditions like pyoderma, or there's some sort of concomitant disorder that is contributing to poor wound healing. And you know a lot of those. Now, a really important factor in chronic wounds is the formation of something called a biofilm. It's essentially a fortress of bacterial bodies and extracellular matrix that can develop over top of a wound and it inhibits healing. There are different phases of bioburden ranging from planktonic contamination, so basically just free-floating and uncoordinated bacteria on any open surface, through colonization and then biofilm. Now, an interesting fact is that some people think that you can see biofilm with the naked eye, and that's what I used to believe. If you saw slough, that represented biofilm, and that is not necessarily the case. So sometimes you can have a perfectly clean looking normal granulation bed. And if you look at it under an electron microscope or under some ultraviolet light, you can actually see that there is actually biofilm there. And in fact, my normal tact is just to assume that a biofilm exists if a wound is resistant to standard therapy. Now, in that previous slide, you may have noticed, if any of you are familiar with the chronic wound literature, that I skipped out a stage called critical colonization. So I went from planktonic bacteria to colonization, straight to infection. And there used to be a phase called critical colonization. And I've left that out because in the 2022 international consensus update from the International Wound Infection Institute, they've left that out because it's kind of a difficult diagnosis. It's sort of that phase where wounds don't heal and they might be sloughy and the granulation tissue looks a little bit different, but they are not overtly infected. And that is sort of a nebulous phase. So I guess they have taken that away. In terms of eliminating biofilm, it is a multimodality process, generally targeted at the local removal of biofilm. It can be done with several different modalities, including different types of debriding dressings. And Corrine's going to take us through a few of those different dressings later on in the talk. From a physician perspective, we can also try other things like sharp mechanical debridements. I'm not sure how many of you in your clinics have the ability to do either curettage or scalpel debridements. That's very, very useful in chronic wounds. And then we have options of enzymatic debridement as well. So things like Santal. Some other modalities to eliminate biofilm are listed here. The only one we have access to in the complex wound clinic are maggots, and they're a little cumbersome to use. They take some attention. Things like low frequency ultrasound, electrical stimulation, light therapy, diathermy, laser therapies, I would consider them to be advanced modalities. Again, we have never been funded at the Fraser Health Complex Wound Center to do these things. My understanding is that they work. They're good if you have access to them, generally speaking, in some sort of private setting. I've never known MSP to pay for many of these. Okay, so next thing to consider for chronic wounds is that they can move on to infection. So it's important to sort of understand that progression from, again, increasing bacterial viral burden to erythema and warmth from the wound purulent exudate. This bottom item here, a wound that probes to bone, most of the ID guys in the region will accept that as proof positive that you're dealing with an osteomyelitis or localized infection of the periosteum. And then this isn't something we see that often: systemic infections, constitutional symptoms, fevers, chills. Again, an indication that your infection has gone beyond the local bounds, is into the bloodstream, and is causing systemic symptoms. To start, it's really important to have a conversation with the patient about their goals of care. Now, generally speaking, when we see patients, their preference or their goal is to have their wound healed. And the bottom line is, sometimes, especially with chronic wounds, wounds are not healable. They have some sort of underlying condition that just does not allow that to be the case. But I have to say, for the most part, that situation is rare, where physiologically, because of their underlying medical condition, there's nothing that can be done. More often than not, when we see patients at the Complex Wound Center who've had wounds for months to years, it is because they haven't actually received standard care yet, or consistently over the last several months to years. So that's an important factor. And then the other is that a lot of these patients, for various reasons, often socioeconomic, they cannot actually do what is needed to be healed. And that's a difficult situation, I imagine many of you deal with, where you kind of know what they need, but the patient either has to work, or they can't make their appointments. They can't do the number of dressing changes, or stay off their feet because of different factors. And that's all consideration when formulating a wound treatment plan. There is this large middle area, which we've classified as maintenance wounds, that are really, really difficult to negotiate. Often requires a multidisciplinary team. It's important to have very frank conversations with the patient right up front about what their goals are. Is their wound healable is the starting point, but how far are they willing to go with regards to healing their wound? Frankly, there are some patients where wound healing is not a viable option, or not the best option. We have a lot of conversations at the clinic about whether or not patients are better off with, say, something even as drastic as an amputation, getting fitted with a prosthesis, getting mobile again, and getting on with life, as opposed to spending months to years in wound clinics or in hospitals, dealing with their wounds or other complications. So again, that is a very difficult conversation. It takes a lot of time for patients to get into the right headspace for that. And sometimes that is better done by someone other than the physician, or in the context of a multidisciplinary team. Again, part of that conversation is really spending a lot of time with the patient, talking about what matters most to them, how much treatments will cost, what effect things will have in terms of quality of life with their families. Again, difficult conversations to have in the context of sometimes the family physician's office, better done, in a context of a multidisciplinary team with quite a bit of support. Now, in terms of actual medical physiologic things that you need to think about when you're dealing with a chronic wound, I tend to categorize them into local factors and general factors. There are certain local things that in their presence, a wound is unlikely to heal. Things like foreign bodies, infection, if there's no blood supply, if they've had previous radiation, or if there's some sort of physical stressor to the area, such as in the case of a diabetic foot. They all develop callus because of the shear factors involved. Those lead to chronic wounds. And then there are general systemic things as well. Nutritional deficiencies, diabetes leads to microvascular obliteration, which leads to poor blood supply and ischemia, and neuropathies as well. Sometimes cancers are there, chemotherapies, immunosuppressants, and then various congenital conditions, which are rare, but you have to keep them in mind. But again, as I said earlier, most of these signs and symptoms, there are more common things that we see, and it does become a case that most of the chronic wounds that we see at the clinic are a matter of pattern recognition, which makes it much easier to sort of diagnose and treat. For example, we all know about peripheral artery disease can lead to non-healing wounds. You have signs and symptoms remote from the wounds, like muscle wasting and hypertrophic nails. They can have thin atrophic skin and a lack of pulses. And then the wounds themselves, other signs and symptoms like claudication, rest pain, ruberon dependency. And then the ulcers themselves tend to be on the leg anyway. They tend to be on the lateral aspect of the leg because the main blood supply goes down the medial aspect of the leg, and then the lateral supply is what the watershed areas are. They tend to be punched out and quite distinct. They can be quite deep. If you see a wound with necrotic material within it, tends to be arterial in nature, sometimes complicated by infection. In terms of assessment for peripheral arterial disease, it's useful if you have access to it to get things like vascular studies, ankle brachial indices, toe pressures. I know that's not something commonly available in GP offices. Ordering things like ultrasound, angio, CT angio, but what they really need is a vascular surgery referral. And I understand that the vascular surgeons have different things that they're asking for. In Fraser Health, we are trying to work on a vascular referral standard, where the vascular surgeons can give us some sort of consensus opinion on what they want before their referrals. And again, a discussion of patient goals is critical when we're talking about peripheral arterial disease. Vascular surgeons are getting better at things like that, microvascular stenting and things like that. But we all know that their success rate is pretty it's not that great. In terms of venous stasis, again, in terms of pattern recognition, these tend to be larger patients with edema. Their pain tends to be worse with dependency, better with elevation. You have these findings of stasis dermatitis, which include hemosiderin staining, so that brown underlying hemoglobin pigment staining of the interstitial tissues. And then the stasis dermatitis is more that underlying pink. Often their legs are quite warm despite potentially not having any pulses. Venous stasis ulcerations tend to be on the medial aspect of legs, although not often. They can be circumferential, tend to be superficial and quite clean looking, associated with other findings such as the spider nevi and the varices that you can see here. And then in very bad cases, you can see this kind of looks like a white tattooing. That's called atrophy blanche, which is a fibrotic sign, sort of an end stage venous stasis finding. Tends to be around the medial malleolus, but pathognomonic for chronic venous stasis. Again, ulcerations tend to be medial, clean, serpiginous borders, very painful. So again, that pattern recognition that I was talking about. Treatment for venous ulceration is to try and treat the underlying venous stasis. So it is all about consistent compression. I often prescribe a peri-wound betamethasone, a low-potency steroid cream, because the problem with venous stasis is they are stuck in that second inflammatory phase because of all that retained blood product. So it is essentially a localized low-grade inflammatory system because of all that retained product. So sometimes a little bit of peri-wound steroid will actually help to reduce that inflammation and stimulate some ingrowth. We encourage them to elevate their legs whenever they're not on their legs. We encourage them to walk as much as they can because your calf muscle is your body's natural pump mechanism for getting rid of venous return. Weight loss is important. And then there's a good Cochrane review out there about the use of Trentol or pentoxifylline as a rheostatic agent, a fluid dynamic agent for getting venous blood out of your system. So good evidence that Trentol actually improves outcomes in venous stasis ulceration as well. Diabetic foot ulcers, you all know that diabetes leads to microvascular compromise, which eventually leads to peripheral neuropathies, which tend to be glove and stocking in nature. And so that in itself with the microvascular compromise decreases capacity for wound healing. But the main underlying pathology for diabetic foot ulcers is the fact that they are neuropathic. They can't feel their feet and toes. There are certain areas of their feet that are subject to more friction based on their gait, typically the balls of the feet, so the metatarsal heads, sometimes the tips of the toes, and the medial aspect of the heel. They develop callus, it dries out, it cracks because of the neuropathy. They don't feel it, and then this can erode down into normal tissue, eventually bone, leading to things like osteomyelitis. Neuropathic feet, again, they're paresthetic, they can be dry, they can develop areas of heavy callus and muscle atrophy. Again, the primary treatment for diabetic foot ulcers is offloading of their feet, because again, the primary underlying pathophysiology is friction, leading to ulceration, leading to complications. So important to work with people like orthotists or podorthists or podiatrists who can fashion that sort of footwear. If you have the ability to debride callus, callus is both an indication of friction, but also is also a physical impediment to the edges of a wound coming together. At the Complex Wound Clinic, we offer something called a total contact cast, which is nothing spectacular. It is just a fiberglass cast that you would use for a broken leg. But what it does do is it perfectly redistributes the forces around the foot. There's an element where it's heavy and people just walk less. And I think the most important component is that the patients can't remove it easily. So it's on all the time. They can't cheat. So this is the gold standard. Now, some of you may have recently seen an announcement through Pharmacare and the Ministry of Health that the Ministry or Pharmacare is now funding offloading footwear for patients who have had their diabetic foot ulcers healed through total contact casting, and that is the case. Right now in Fraser Health, I believe our complex wound center and I think one of the community outpatient service at Peace Arch Hospital are the only clinics that actually offer total contact casting. So for your patients with who qualify for fair pharmacare, that may be a consideration for you, given the Ministry of Health will fund their orthotics now if they've had a total contact cast. I'm not going to say a lot about pressure ulcers because, again, in our clinic, we see mainly, we don't see any inpatients. We see ambulatory community patients for the most part. Again, pressure ulcers, more an element of pressure versus shear, which was what we saw with the diabetic foot ulcers. Really, really difficult. You really need to work with a good occupational therapist or somebody who knows how to offload well. More often than not, these require surgical debridements with interpositional flaps. So again, working with a good plastic surgeon and a team that knows how to offload well is very, very important for pressure ulcers. So again, it is all a matter of pattern recognition is what we do. Making sure that we're dealing with the underlying pathophysiologies and getting the patients what they need at the right time. So just a quick review. We see here a heavy calloused area on the balls of the feet. This is clearly a diabetic foot ulcer. Refer to wound care, debride and offload. Here we have some, probably a heavy patient with hemosiderin staining, edema, a wound with serpiginous edges. Not as clean as we typically see, but also on the medial aspect of the leg. This is a venous stasis ulcer. We encourage exercise, weight loss, counsel around leg elevation. We put them on Trentol, we order some peri-wound steroid, and then we refer for wound care and compression. And then this is somebody with necrotic toes, probably pulseless, dry foot. This is an arterial ulcer. Got to treat their comorbidities, including the obesity, hypertension, dyslipidemia. Refer for vascular studies and then a vascular surgeon. So again, all about pattern recognition. Is this acute? Is it chronic? Is there an underlying pathology that is contributing to their non-healing status? We go through a discussion of wound goals, and then we direct them to at the right time. And in our experience, our mandate initially 10 years ago was, to take sort of the worst wounds that we saw in the home health offices, mainly wounds that have been present for anywhere from 3 months to several years, and to get them healed. Initially I kind of thought that was a higher level modality, something like, lasers or a hyperbaric chamber or, localized oxygen delivery, something like that. And in the 10 years I've been at the complex wound clinic, my finding is that 9 out of 10 times, if a patient has a chronic wound, it's because they haven't received a standard of care yet, the standard of care yet. And, that's a statement on how even sort of simple things like we've talked about today are really, really difficult to do in a complex system. And maybe, the best thing to do when you're dealing with not only a chronic wound, but a patient who has the profile for somebody who could develop complications in a long-term wound, might be better treated in a multidisciplinary setting by people who do a lot of this. And we do a lot of these things. So again, I would recommend to you, I would that if you meet a patient like this and you're thinking this patient might have problems in the future, we like to see them as soon as we possibly can. Please reach out, and again, our referral forms are available on FormFast and in Pathways. I think I'm going to pass it off to Corrine now for her portion of the talk, and then we're going to be around for some questions and answers after. Thanks.
There is a quick question in the chat, Dr. Hwang. Did you want me
Sure.
to save it for the end? Sure. It comes from Dr. Ewart. Sorry, I'm just pulling it up here. Where did it go? Sorry, Dr. Ewart, did you want to unmute yourself and you could ask your question? For some reason, it's not coming up on my chat right now.
Sure. My question is there a role for Lasix in patients with chronic venous stasis and significant edema?
Yeah, we think so. It's not something we typically do at the clinic, but there's always usually a significant fluid retention leading to their underlying problem. So we focus on the compression aspect. Usually the edema is more associated with their heart failure, or their renal failure, or some other process that needs sort of a multidisciplinary approach. And certainly if we think that's the case, we either work with a family doctor or with a specialist that we refer to deal with that. Corrine, do you want to take over? I can advance your slides for you.
Yeah, I can. There is another question about, I'm just trying to think if we touch on that question about compression, but I'll come back to that question about determining the right pressure. If I don't answer it, I might not, but come
Sure.
back to that. Okay, so my part of the talk is kind of talking about the local wound care plan that either you would work with a patient to develop independently, or what nursing or the interdisciplinary team would come up with when referred to home health. So first, just going to have an example, talk about goals of care, because the goal of care also impacts the wound care plan that you end up developing. So this is Tilda. She has a venous ulcer. She works 8 hours a day as a typist. She's been custom fitted for compression stockings, but found they were itchy, hard to put on, and didn't match her outfits. She's decided to stop wearing them completely. So the goal of care is for her. Does anybody want to write it in the chat, I guess, or so the goal of care here, obviously, if she's not going to wear compression, is maintenance, because we're not able to address the underlying cause. Sometimes here we're able to provide enough education for her to understand that without the compression, she's not going to heal, and we're able to negotiate a way for her to treat the underlying cause, which is the venous stasis, with the compression and move her towards healing. But that can take a lot of conversation and a lot of time in order for them to understand that they need this compression for life to maintain venous healing. So, and how we proceed with based on a goal of care would be very different for her. Next slide. So in this paradigm, this is the paradigm we sort of like to think of when we're developing a care plan. So first being identify the wound diagnosis, treat the underlying causes, address patient-centered concerns, such as financial, the stockings are itchy, that sort of thing. We can work with a patient to address those local causes or patient-centered concerns. And then we would focus on the what do you put on the wound. The first part of that is debridement. So if there's slough or deep vitalized tissue or a necrosis in the wound, we would look to see if it's appropriate to debride the wound. So next slide. Oh, sorry, cleaning. So yeah, I'll go with cleaning. So cleaning is also a part of the debridement. The solution you choose can help to reduce the local bioburden on there. typically in a wound center, we're using saline and we're using syringes to get a certain PSI to get the bioburden off the wound bed. We use a lot of saline, a minimum of 100 cc's, because the catchphrase is the solution to pollution is dilution. So basically to keep the bacterial load down. When you're dealing with chronic wounds, often we are recommending people shower, not bath, shower their wounds for that same idea that they wash their wounds, they get lots and lots of water on their wounds in order to reduce the topical bioburden that develops on the wounds. So yeah, for chronic wounds, showers are good. For acute wounds, we tend to stay away from the showers. Yeah, so yeah, you can continue slide. So yeah, back to debridement. So we look at the wound to determine if debridement is a good idea. We always want to make sure there's blood flow to the wound before taking away tissue, because once you've removed that tissue in the absence of blood flow, it's never going to grow back. So we always want to make sure that it's safe to remove the tissue first. So you would do your assessment for vascular flow, get vascular involved if necessary, get revascularization if needed, before moving on to debriding. Debridement in chronic wounds tends to fall into the categories of autolytic, enzymatic, or mechanical. There are people out there, physicians like yourself, that can do conservative Sharps debridement. Wound care clinicians in the community can do conservative Sharps debridement, but they're limited in the number of wound care clinicians in the community, so that can be limiting to what kind of debridement you can get. Autolytic debridement is the most readily available. It's the use of your own body to get rid of the slough, and then you would either choose product to optimize that process, or you would create basically a fluid retention dressing to hold on to the body's own fluid in order to create that autolysis. Biological being maggots are really fun to work with, but they're kind of a hassle to get, and especially in our clinic, we can conservatively Sharps debride or that slough away faster than the maggots can work. So we don't tend to order them in because they have to get ordered from the States, but it can be done. And then surgical debridement for the large wounds that require plastics to go in and actually clean out the non-viable tissue. Next slide. So products that we choose when we're considering autolytically debriding a wound, sometimes it's as simple as adding moisture to the wound, an intrinsic gel or something like that. Other times we're actually, like I said, choosing a moisture retentive dressing, like a hydrocolloid or an all dress or Tegaderm or something to hold the moisture in to create a moist environment. Other things that we can use are mee salt, which are hypertonic in nature, or Medihoney, which is also hypertonic, so that it's actually pulling the fluid out of the body towards the wound bed to create that moist environment for autolytic debridement. Yeah, so just another scenario, right? In this situation, you've admitted a client with or assessed a client to have 100% dry eschar on your heel. The question is, what should you do? In this situation, when you have stable eschar, the answer here is to leave it alone. Stable eschar is a protective cap. It's protecting the wound, and probably there's a degree of arterial compromise here. So we tend to leave these alone, keep them dry, prevent infection, and let these heal from within, because it's protected and the body will do its work. It does take longer to go this way, but it is the safer route. So we leave these ones. Paint them with iodine and go. Yeah. So whether or not we use an antimicrobial on the wound is dependent on our assessment, and that's based on the clinical signs of infection. And Dr. Hwang already went through and sort of went through these, but where on this we typically look to see, like, do we need something like a topical antiseptic to help this wound care plan forward? It would be in that localized infection. a fresh acute wound that's healing well doesn't typically need anything if you've got a healthy, strong immune system. The body's immune system takes over. Once you start to notice slowing of the wound, increased slough, increased size of wound, but it hasn't extended to the edges of the wound, you're starting to need a topical antiseptic to reduce the bioburden and move the wound healing forward. Once that wound bacteria is in the peri-wound and you've got more local signs of infection, your erythema, then we're actually needing to have antibiotics on board. So it's that critical colonization area, that's gray, where we use the antimicrobials for topicals. And some of those are, next slide. Oh, I guess this is a review slide. So when we're looking at this photo and trying to decide what needs to be done for this photo, in which phase of infection is it in, this has obviously gone beyond 2 centimeters of the wound margin. It's quite wet looking. And this is more into that infection piece. So while you may choose to put an antimicrobial on this, you're likely going to need to have antibiotics on this as well. So whether we go with a broad spectrum, see if it works, or then swab it to see what your specific bacteria growing is for this situation. With whether you're using it with or to prevent infection, the antiseptics and antimicrobials, there's a bunch of different categories. So what's available to us in Fraser Health is quite broad. There's iodine-based products, chlorhexidine-based products, and then in our antimicrobials, we have lots of silver-based products. PHMB, MediHoney, Hydrofera Blue. Essentially, all of these products kill bacteria. We tend to choose them based on what what else is going on with the wound. Silver products tend to be a little bit of anti-inflammatory. Iodine products tend to be a bit pro-inflammatory in their nature. So when we're looking at the wound bed, trying to decide what do we need it to do, Hydrofera Blue is one of my favorites. It's Gentin Violin and Methylene Blue, and it's in a foam dressing that you keep moist. So you're optimizing the autolytic debridement as well as killing bacteria, and that tends to get you debridement as well as bacteria killing, and you're able to move that wound forward. Yeah, let's move on. Moisture balance. So this is tricky because you have to decide if you're going to heal the wound by dry wound healing or moist wound healing. Best practice is that as long as you have good blood flow, you're going to be, the wound's going to heal faster if you use moist wound healing. But you got to balance that. It can't be too wet or too dry. You're trying to optimize like sort of the moisture of your eye. It's not always the case. Sometimes if you're more of a maintenance wound, you're going to want to actually err on the side of drying the wound out, and because you're creating a more or a less hospitable environment for bacteria when you are trying to dry the wound out, versus a moist wound environment would be more at risk for infection, especially if you haven't addressed those underlying causes of the wound itself. So yeah, it's on the line of moisture balance. This wound here, obviously way too wet, lots of maceration, and you're just not going to get that wound proliferation and tissue advancement when the wound is this wet. So in a situation like this, a couple of different things we could do. We would try to find maybe a dressing that transfers the fluid away from the wound bed onto an outer dressing, use a more absorbent outer dressing, or change the dressing more frequently in order to prevent and protect that maceration. Skin that's wet is more susceptible to further damage and just won't heal. So products is our best sort of weapon against this. So with classic pads, which Those ones are in the incontinence line, so very absorbent, designed to absorb urine. So very good at absorbing wound fluids. They typically are not sterile in nature, but we don't worry about that as much when we're talking chronic wounds because these are all colonized anyway. Mesorbs, a good absorbent outer dressing. And then some of the times you can layer products inside your dressings like hydrofibers or alginates that are absorptive inner layers that you would add to the wound care plan. On the retentive products, sometimes you're actually wanting to create or trap the moisture to create a moist environment instead of it drying out. That's typically towards the end of healing. So that's where you would be applying hydrocolloids, maybe some triads, or a combination dressing like all dress. So always important with moisture balance to protect the peri-wound skin from damage. So we use skin prep or certain creams like silicone cream, EPC. If the skin is really cracked, then we may end up having to use a Tractane, which has pseudosilic acid and uric acid in it to both debride and hold on to moisture. And we typically use that for like diabetic feet with really cracked heels, and then just good moisturizing skin just to protect. Yeah, next slide. So with the edge effect, you want to make sure the wound base is coming up and then the edges are nice and attached and they're coming in. Lots of things can delay this, including incomplete addressing of the underlying cause, getting stuck into the inflammatory phase. And then you may have to use some more advanced dressings that are available through home care or at the complex wound clinic. And these tend to be matrix dressings for collagens or, yeah, so we do have a number of them that we can use if we're not seeing the wounds advanced, despite best wound care. And this is a very nice picture of a wound that's healing with a very nice edge, nice granulation, and good healthy epithelial on the edge. This is an ideal wound edge, and we would expect this to continue to heal. So yeah, basically it's a lot. It's a very specialized thing, yeah, there's lots of resources out there. Sometimes it is a bit tricky to find them. So like I mentioned, in Fraser Health, every community has access to a wound care clinician through home health. There's nurses there, there's physician experts in different areas. And then, I mean, sometimes we have to send people to the emergency department because that is the way into advanced care for infectious disease or vascular in an emergency situation. So, question. So I do see a question here about ABIs and compression. And John, do you want to answer that, or do you want me to answer that?
Oh, we could probably both say something.
Okay.
I mean, for compression, generally speaking, if you can go to 30 to 40, that's what you're trying to do is overcome venous pressures, right? Venous level pressures. And I know there's always a concern that in a sort of a borderline limb with questionable arterial supply, by putting compression on, you're pushing them into this sort of the ischemic realm. And unless you have a critically ischemic leg, like somebody who has claudication, has pallor on elevation pain, rubor on dependency, has night pain, like really end stage arterial disease, you're not going to do that with compression. So I know that is a concern, but generally speaking, when I order compression, it is more a consideration of what the patient can tolerate. So sometimes they find very tight compression too uncomfortable. They end up taking off the stocking. And in that case, a little bit of compression is better than no compression at all. depending on the shape of the leg, they might need different things, different types of stockings or garments or wraps, which takes some expertise in terms of what to order. But generally speaking, I'd go right to full compression. Corrine, what do you think?
Yeah, so I mean, when you're saying compression, it depends if we're talking compression stockings for prevention or compression wraps for healing. The nursing standard to apply compression wraps is that there is an ABI completed. So if you are sending an order to home health for compression wraps to heal a venous ulcer, they will need to do an ABI before starting those compression wraps. And the parameters they use for that is that anything less than 0.9, you're going to get a modified compression of 20 to 30 versus 30 to 40. And as long as, so but of that has to be over 0.5 in order to get that 20 to 30. Anything under 0.4, they're going to be recommending a referral to vascular in order to consult whether compression is appropriate for that, or should there be some revascularization at that point. For maintenance compression stockings, so once they're healed up and they're determining whether they need what strength of compression stocking they need, I could agree with John, if they can tolerate and apply 30 to 40, that's your best bet for prevention. That said, in the elderly population, getting those tight stockings on is very hard. And so often people end up in a 20 to 30, just not because they couldn't tolerate the pressure of 30 to 40, it's just they can't get them on and they can't incorporate that strength into their lifestyle. Okay, so, and then just one more thing on compression is just related to if you have a patient who's homebound and getting home support, they will need regular ABIs just because it's a delegated task. And in order for the nurse to delegate that task, there needs to be a regular ABI done so that it can be delegated to home support workers to apply the stockings safely. Yeah, so the next question I'm seeing here is, do we have specialized service in Fraser Health for nail care for those who are 65 plus with
Fungal infections.
Oh, no, we don't, unfortunately. Nail care isn't covered by MSP services, so it's considered something you need to take care of yourself. Unfortunately, there is some work that's being done provincially advocating for these services, but nothing that is available outside of the private sector.
Any other questions? Go ahead and unmute yourself or type them into the chat, and we're happy to field whatever you have. Okay, well, if there's nothing else, we'll close the presentation, and we'll provide our slides through April, and our contact information as needed. And again, we're happy to take your referrals at the Complex Wound Clinic as you need us.
Thank you so much, Dr. Hwang and Corrine. Thank you so much for the time that you spent and the great information. For those of you who are curious about the slides and whether you came in just a few minutes late and you're wondering if the lecture is going to be online, yes, it is. Give us a couple of days. We'll have the full lecture up on our SND YouTube channel. We'll send out the slides for you. I'm also putting in the evaluation link into the chat, so please just go ahead and fill that out. That way you can get it over and done with. And we can send you your sessional and your CME credits as soon as you're done your evaluation. So once again, thank you so much. We learned a lot this evening. We really value and appreciate sharing your knowledge with our physicians and our community. So we really appreciate your time. And big thanks. And for the physicians on the call tonight, thank you for spending a bit of time with all of us. Hopefully you got some questions answered, and certainly please, if you think of anything else that you wanted to ask after we close up for the night, please feel free to send it along my way and I can forward it as well. Well, thanks again so much, everyone. Once you're done the evaluation, you can drop off the call for tonight. Thank you, everyone.